Medicine is a science of uncertainty and an act of probability, as said by William Osler. Our clinico-pathological conferences are a journey through clinical reasoning, diagnostic exploration, and pathological revelation. Good morning, respected learned dignitaries, seniors, and my dear colleagues. I welcome you all to the enlightening CPC of today by the Department of Pediatric Surgery. Without much ado, I would first like to welcome all the dignitaries onto the dais. Now I would like to welcome respected Principal and Controller, Dr. Deepak Maheshwari, sir, the driving force of the CPC onto the dais. So please adorn the dais. Now I would like to welcome the mastermind and convener of the CPC, Dr. Puneet Saxena, sir, onto the dais. So please take your seat on the dais. Now, I would like to welcome the co-convener of the CPC, the executioner of the CPC, Dr. Monica Jain, ma'am, onto the dais. Now, I would like to welcome the host of the CPC, the head of the Department of Pediatric Surgery, Dr. Arvind Shukla, sir, onto the dais. As the procedure goes, I would like our principal and controller, sir, to welcome you all to the CPC and say a few words.
Thank you. Good morning, everyone. Sabko namaskar. I think colleagues and students. So I think pediatric surgery is the next difficult thing on the earth after deep sea diving, huh? So it is one of the most difficult branches. They have to put a lot of effort and energy. I am informed that this is the first MCH course started in our college in 1978. And almost 112 candidates has passed. And they are doing surgery around, say, 5,000 surgery per year, which is maximum in the country. Great effort, sir. The department is dealing with around 1,500 neonatal surgeries, including congenital malformation per year. So this department had very many stalwarts and doing very good work. So I think this is a great pride to be here in the CPC of Pediatric Surgery Department. Thank you.
Thank you so much, sir. Now I would like to welcome convener of the CPC, Dr. Puneet Saxena, sir, to present the SOP of CPC.
Yeah, good morning, everybody. Principal, sir, Dr. Monica, Dr. Arvind Shukla, my seniors, Dr. SM Sharma Sahib is there, Dr. Rajni ma'am, Vanna ji, and everybody, Dr. Pidaji, and all the seniors and friends. So we are continuing with the journey of CPC, and it's going very well. And every time we see an interesting case. Just now the principal said that the department started in 1978, pediatrics. 78, 71, sir? 71. So this is a pioneer department again. One of the best part of coming here is not only the academic, but to know about your own college and hospital also. And probably the younger people are missing that opportunity, but we are learning every time in the CPC that what's happening in our own institution. And it's very heartening to know that majority of the MCH working in India in pediatric surgery department have passed from this department. So we probably own almost all departments running in this country, where we have seeded our own students across the country. So that is what it was started by. Dr. Shukla will take over the details of the department. So moving on from here, sir, we had a suggestion just now where Dr. Vanna Mangal suggested that if the department who is presenting the CPC is interested to relay the CPC to their respective departments across the state or otherwise, so probably if somebody is interested, we can make them join on this interesting case and the journey of the department. That's a good idea. So this is a good idea. We can think over that, and we'll work on that also, madam. Right? So that's a very nice idea. So the SOP, we all know by now that we know about the department, and then we do a case which is basically, it touches across the multi-specialties, so it can, and it has to be a very interesting and an unusual case, because we want to this case to be presented in a journal or to be recorded in the compendium of CPC, which will do it when we finish all the CPCs of all the departments. So with that, and the next CPC, if somebody is here from neurosurgery department, so the next CPC would be from the neurosurgery department, and I think we'll inform Dr. Manish Agarwal, who is heading the department. And with that, I hand over here and over to Madhu.
With this, I now welcome Head of the Department of Pediatric Surgery, Dr. Arvind Shukla, sir, to narrate the glory of the department.
Honorable Principal, sir, Convenor CPC, Dr. Puneet Saxena, sir, Additional Principal Abhishek Agarwal, sir, Co-Convener CPC and Additional Principal Monica Jain, Madam, Dr. SM Sharma, sir, my colleagues and friends. Now, I welcome all of you for the CPC organized by Department of Pediatric Surgery today. I will like to tell you something about the Pediatric Surgery Department. Dr. K.C. Sogani was among the pioneer pediatric surgeons of India, trained in UK and USA. A unit of pediatric surgery was created under Dr. K.C. Sogani on 1st July 1965. He did his first successful surgical repair of tracheoesophageal fistula and esophageal atresia anomaly in the country in 1971, and that patient was survived. He served as the first medical superintendent of Jain Hospital and served the department till February 29, 1988. Later on, need of a separate pediatric surgery hospital was felt, and due to perseverance of Dr. Sogani, a separate children's hospital came into existence on 26 January 1980. One unit, 40-bedded unit of pediatric surgery was shifted to a new children's hospital, popularly known as Jain Hospital, in the year 1980. Ours is the first super specialty department in SMS Medical College, Jaipur, to start MCH course in 1978. So far, 112 MCH students have passed from the department. The department is one of the largest contributor of pediatric surgeons in India. At present, the department has 10 MCH seats per year recognized by NMC. Currently, the department is preparing future pediatric surgeons with advanced techniques and knowledge like pediatric laparoscopy, video-assisted thoracoscopy, pediatric urology, pediatric neurosurgery, endoscopy, and clinical research. The department deals with the maximum number of congenital diseases in the world, including anorectal malformations, neurosurgical diseases, intestinal atrasias, conjoined twins, urogenital disorders, and other congenital malformations. At present, the department has 4 fully functioning pediatric surgical units, 2 surgical ICUs, 2 nurseries, with a total bed capacity of 200, which is largest in the country. There are 4 pediatric surgery units, and this is the faculty position in our department. This is the unit-wise distribution of faculty in the units. These are the students, MCH students who passed from the pediatric surgery department. They did MCH here. We have got a wonderful anesthesia department under leadership of Dr. Neelam Dogra ma'am. She is serving in the department since last 27 years, and her expertise is being used by the department. Total bed strength is 200, among them 227 ward beds and 33 nursery beds and post-operative ward and surgical ICU. These are the yearly statistics of our department. This is our outpatient department. Average daily OPD is around 153 patients, and we do minor procedures in our OPD. 50 to 55 procedures are done in OPD. Surgical, this is these are our surgical wards. Average daily admissions is 20 to 25. In summer and vacation period, admission rises up to 40. This is our theater complex. Average daily major operations are 20 to 25, and in vacations and in summer season it rises up to 40. It is a big number for a theater. We are running 6 full-fledged operation theaters per day, including 2 emergency operation theaters which run 24/7, which includes 2 medular OTs, 1 fully dedicated laparoscopic and endoscopic OT, and exclusive neonatal surgery OT is there. Around 4,500 surgeries are being performed every year, which is highest number in India. The number of patients managed are twice that of AIMS, Delhi, JIPMER, KEM, Mumbai, PGI Chandigarh, SG, PGI Lucknow, and CMC Vellore. Recently, one OT was converted to modular theater. The department is widely known for performing a very large number of surgeries for tracheoesophageal fistula, hypospadias repair, biliary atresia, and newborn and childhood malignancy, including sacrococcygeal teratomas, neuroblastomas, Wilms tumor, and lung cysts. Laparoscopic procedures are being performed since 2008. We have got 2 laparoscope sets, 1 neuroendoscope set, 1 thoracoscope set, 2 cystoscopes, esophagoscopes, and bronchoscopes. This is our post-operative recovery room. This is our and it is in OT complex, which save our time during patient recovery and shifting. This is surgical nursery. 2 surgical neonatal nurseries are in the complex of 33 beds with all facilities for pre and post-operative care of neonates. These nurseries are handled by pediatric surgery faculty and resident team, which also give opportunity to train our residents in neonatal care. This is the new neonatal transport incubator used to transport neonates with oxygen support and temperature control system. And this is latest bubble CPAP machine in our department. This is pediatric surgical ICU. There are separate ICU ward for care of patients having 18 beds capacity with ventilators, oxygen supply, multi-para monitors, USG machine, X-ray machine facilities. This is portable USG in our ICU and pediatric defibrillator. This is post-operative surgical ward, 14-bedded post-operative surgical ICU ward attached to OT complex with state-of-art ICU setup with ventilators, portable USG machine, X-ray machine, etc. Apart from a well-established college central library, a nicely organized small departmental library having all textbooks and reputed journals is well maintained, which is accessible round the clock. We are also running a simulation lab for faculty and residents to improve their laparoscopic skill. Conferences and workshop organized by our department. Annual conference of IAPS in 1974, 1983, and 2007. Jointly hosted 10th Annual National Conference of Pediatric Endosurgeons Group of India, PESI and IAPS Con in 2015, International Workshop on Pediatric Urology 1998, Operative Workshop on Pediatric Laparoscopy 2008, Publications, Award and Honors and Achievements of Faculties. Honor of having President of Indian Association of Pediatric Surgeons in 1983 and 1984, Dr. K.C. Sogani. In 1995, Dr. A.K. Sharma. Professor Shyamvari Sharma served as executive member of IAPS in year 1995-96. Dr. Arvind Shukla was executive member of urology section of IAPS 2022. Professor Arvind Shukla was medical superintendent of Jekyllon Hospital September 20 to September 22. Dr. Praveen Mathur was additional principal SMS Medical College in recent past. Awards. Former professor and head Dr. Narpal Singh Shekhawat was awarded Dr. B.C. Roy Award by the President of India in 2006 for his contribution in field of socio-medical science. He also served as medical superintendent of SMS Medical College and Jekyllon Hospital. Dr. Shekhawat was also principal of RUHS Medical College. State Merit Award. Professor K.C. Sogani in 1984, Professor Narpal Singh Shekhawat in 2002 were awarded the State Merit Award for the meritorious services for the Government of Rajasthan. Former Professor and Head Dr. Ram Babu Goyal and Professor Praveen Mathur were awarded merit certificates by the Government of Rajasthan in 1996 and 2000 respectively. Dr. Arvind Shukla is one of those who have done maximum number of hypospadias surgeries by a single surgeon. These are the publications by him. Publications of the department. The department has credit of nearly 400 publications in reputed peer-reviewed national and international journals. At present, around 10 research projects are running. Among those, 2 artificial intelligence-based projects are in collaboration with IIT Madras. Recent development in the department. Recently, we have developed a new 50 seating capacity, air-conditioned, well-equipped classroom. These are the achievements of residents. In the last few years, our residents presented around 25 papers in various national conferences. In 2023 IAPS conference, our resident Dr. Vinayak got first prize, and in 2024 IAPS conference, best paper award was given to Dr. Aditya and Dr. Vinayak. Dr. Ashish Verma was awarded gold medal from the Principal SMS Medical College in 2025 university exam. We are planning to upgrade the department by adding robotic surgery and urodynamic study equipments in our department. For the same, we have discussed with our principal sir, and he gave us a very positive response. We are thankful to him for this support. The Department of Pediatric Surgery is known for its dedication and skill towards neonatal and pediatric patient care. Patient satisfaction rate is 100% according to survey conducted by different agencies. Pediatric Surgery Department is involved in management of congenital malformations. Department is dedicated to child care and concerned towards agony of small patients. Thank you and happy Independence Day in advance. Dr. Suraj.
Good morning, everyone. I'm Dr. Suraj Girish. I'll be presenting a case on unusual perineal mass in a neonate, diagnostic difficulties and clinical insights. Coming to the history, a 2-day-old male child presented with a complaint of a mass protruding from the anal canal since birth. The informant was the mother and was reliable. So the child presented with a reddish mass protruding from the anal canal since birth, and there was no associated complaint related to the mass. The child was otherwise healthy and had a good cry. The child was born to a 21-year-old healthy mother in a non-consanguineous marriage. Birth order was 1. The mother underwent regular antenatal checkups and was normal and took regular iron and folic acid supplementation. The child was born at term via normal vaginal delivery at a hospital, cried immediately after birth, and was breastfed within 2 hours and passed meconium within 12 hours of birth. Family history was insignificant, and there was no history of similar complaints among the parents or other family members. And the child received BCG, OPV, and hepatitis B vaccinations at birth. Coming to the general physical examination, the child was examined in supine position on the examination table. It appeared comfortable. It was adequately built and nourished. The weight was 2.9 kg, which falls in the 25th percentile. Length was 48 centimeters. And head circumference was 36 centimeters. Vital signs were stable, and there was no evidence of pallor, ectocyanosis, lymphadenopathy, or edema. Moving to the systemic examination of the abdomen, on inspection it appeared flat. The umbilicus was inverted and centrally placed. All quadrants moved equally with respiration, and there were no sinuses or dilated veins. On palpation, the abdomen was non-tender. There was no hepatosplenomegaly, and normal peristaltic sounds were heard. External genitalia appeared normal. On examination of the cardiovascular system, there were no added sounds, and the 2D echocardiography which was done was normal. The rest of the systemic examination was insignificant. Now, coming to the local examination, at presentation in the neonatal age, on inspection, there was a 2 by 2 centimeter globular pedunculated mass noted to be arising from the anal canal. The surface was covered by pink mucosa. It appeared lobulated, and the surrounding skin appeared normal. On palpation, the mass was found to be arising from the right anterolateral aspect of the anal canal, about 1.5 centimeter above the anal verge. The consistency was firm, it was non-tender, and did not bleed on touch. On rectal examination, the anal opening was found to be narrowed due to compression by the mass. Also, an indentation was felt over the anterior and right lateral aspect. There was a mass extending from just above the dentate line till 4 centimeter proximal to the anal verge. This mass was firm in consistency. The surface was nodular. The mucosa was freely mobile and was not ulcerated, and it was non-tender. Now, based on the history and physical examination, we concluded that there were 2 masses. One was arising from the anal canal and one mass in the perineum. And based on these, we had several differentials in mind. I would like to discuss the most obvious differentials and the most commonly one which we encountered. The first which we thought of was infantile hemangioma. Why? Because it is seen in 4 to 5% of all neonates, and it is 5 times as common in females than in males, which goes against this case. And the presentation was also of a soft, painless, red-purple mass with a rapid growth in the first 3 months. This is a representative image of an infantile hemangioma in the perianal region. The next differential was that of a lymphangioma. It was fairly common with 1 in 6,000 live births, with 5 times as common in males than in females. Again, it is a soft, painless, slow-growing mass, which is commonly seen at birth. Here's a representative image of a perineal lymphangioma. And the third differential was a tail gut cyst. Again, 3 times as common in females, incidence of 1 in 40 to 50,000. They can present with perineal fullness, urinary retention, dysuria, rectal bleeding, and constipation. This is a representative image which shows perineal fullness. And lastly, we had a rhabdomyoma, which is a very rare tumor, 1 in 20,000 live births. Again, it's an asymptomatic, slow-growing tumor. Apart from this, we also considered hematomatous polyp and meningocele, both of which are very rare and quite unlikely. This is a representative image of a hematomatous polyp and for an anterior sacral meningocele. Now, moving on to the malignant differential diagnosis. Here, mainly we kept 3, but considered 2. That is the sacrococcygeal teratoma, which is the most common perineal tumor in a newborn, and the rhabdomyosarcoma. Again, the presentation is very similar to what we had with the perineal fullness and a fleshy pedunculated mass. This is a representative image of a sacrococcygeal teratoma, and this is for a rhabdomyosarcoma. Apart from this, neuroblastoma was also considered, but again, it is mainly an abdominal swelling and not a perineal swelling. Now, based on this, we kept a provisional diagnosis as infantile hemangioma, tail gut cyst, rhabdomyoma, SCT, or rhabdomyosarcoma. I would like to invite the audience to suggest any other differential diagnosis that you might have in mind. Moving on. Once the physical examination was completed, we proceeded with radiology. I would like to invite Dr. Naman Gupta to present the radiological investigations.
Good morning, everybody. Now I'll be presenting the radiological overview of this case. So we got a patient, 2-day-old neonate with a visible external swelling in the perineal region, and we found that this was the lesion, and this lesion was mainly located in the right lower pelvic cavity, and it was seen extending outside into the subcutaneous tissue of the perineal region. And the approximate size of this lesion was around 4 into 2 into 2 centimeter, and the margins of these lesions were relatively well defined. There were no loss of fat planes anywhere, and there were no cystic components, no calcifications. And on color Doppler, we found some patchy internal vascularity without any high velocity signal. So based on ultrasound, we thought that MRI should be the next investigation for this. So these are the MRI pelvis findings. We found that this is the lobulated heterogeneous T2 hyperintense lesion located in the right lower midline pelvic cavity, and this is the external component. Both the lesions are the same. The lesion is encircling the anal canal and extending outside, which we could see on the physical examination. So this was the fat planes were relatively maintained. There were no necrotic components, there were no calcifications, and there was no any cystic component inside this lesion. The lesion was located between the prostate anteriorly and the rectum posteriorly, and the fat planes with both of these structures were relatively maintained. And this is the post-contrast images. It showed heterogeneous post-contrast enhancement. So it was basically a solid pelvic perineal mass lesion with preservation of fat planes. There was no frank invasion, no necrosis, no cystic component, no calcifications. So based on this lesion, our differential favors benign mesenchymal neoplasm. And there could be some low possibility of early malignancy also. So benign mesenchymal tumors could be angiomyxoma, desmoid tumor, rhabdomyoma, solitary fibrous tumor, cellular angiofibroma. And these often present as a large, slow-growing lobulated lesions with sharp margins and preserved fat planes. Even when spanning more than one pelvic compartment, they typically displace rather than actively invade adjacent structures. Other possibility of early malignant neoplasms, such as embryonal rhabdomyosarcoma or a myxoid liposarcoma, cannot be entirely ruled out. These usually show these are rapidly growing mesenchymal malignancies, and these usually show interval progression on follow-up scan. So these are the differentials based on our initial imaging correlation. It could be benign, as I mentioned, and it could be either malignant early stage rhabdomyosarcoma, and it must remain in differential diagnosis, as initial scan deceptively mimicking benign tumors also. So based on the differential diagnosis, USD guided co-natal biopsy was performed and sent to the Department of Pathology for histopathological examination and further evaluation, and we advised a follow-up scan from our side. So I'll request ma'am from pathology department to hand.
Good morning, everyone. So I'll be covering the pathology part. We received in our department a single block for the immunomarker study. So at 10x, we observed that the lesion was of varying degree of cellularity. It was a spindle cell lesion. There were some densely packed hypercellular spindle areas, and in the background, these are the loosely textured myxoid areas. Now at the high power, most of the cells are spindeloid. They are oval to elongated. They have dense eosinophilic cytoplasmic extension. And if you look at this arrow, these are pointing towards these parallel lines which were seen in the cytoplasm, which are the cross striations. So these point towards the skeletal muscle differentiation. However, the thing we noticed was that the pleomorphism was only minimal. The nuclei were almost, they were not displaying very pleomorphism. But the thing we observed and was very consistent was there was no necrosis in the slide, and the mitosis was almost inconspicuous. So, in order to confirm the histogenesis of the tumor, we applied immunomarkers. The first marker we applied was Desmin. Now, Desmin is the marker which is the antigen is located in the cytoplasm. So, we observed diffuse positivity in the cytoplasm, which is seen as the brown color. Now, Desmin positivity can be seen either in skeletal muscle or in the smooth muscle. But since we observed fine striations, so we wanted to confirm the skeletal muscle differentiation, which was done by these confirmatory marker, which are the myogenin and the myo-D1. Now, myogenin and myo-D1 shows nuclear brown color positivity. So we can see that brown color positivity is observed in the tumor cells. So skeletal muscle differentiation was confirmed. Now, the next step was to look for the proliferative potential. Now, how will the tumor behave? Since no necrosis and no mitosis was seen, so we were not sure that whether this is benign or malignant. So for that, we put Ki67, which is a proliferative marker. Now, Ki67 is also a nuclear marker, which is seen as brown colored positivity. Now, in the areas of hotspot, now hotspots are those areas which are rapidly proliferating areas in a tumor. So the Ki67 was as high as 30 to 40%. Now, summarizing, we narrowed down our differential to fetal rhabdomyoma and embryonal rhabdomyosarcoma. Now, the points in favor of fetal rhabdomyoma, the mitotic figures were almost rare, pleomorphism was very slight, and necrosis was not seen. Even in the radiology, as discussed by Dr. Naman, no necrosis was seen. And the tumor was well circumscribed because the fat planes were almost well maintained. The only point coming in favor of rhabdomyosarcoma is the Ki67, which was quite high. So we gave the diagnosis as a mesenchymal neoplasm of skeletal muscle differentiation with uncertain malignant potential. And in view of high Ki, it was advised to submit the resection specimen for exact categorization. Now I would like to invite Dr. Suraj to continue with the discussion.
Now, once the histopathological diagnosis was concluded, we advised the patient for surgery, but they refused and were lost to follow up for 2 months. And when they presented after 2 months, they presented with an increased size in the size of the mass, constipation and dribbling of urine since 15 days. Here we can see the mass at the second presentation and the initial neonatal size. The mass had increased by almost 3 times. Now, apart from this, the mother also complained of fullness in the bilateral buttock region, right side more than left, which was not present earlier. And on examination of the external component, on inspection, it was a 5 into 5 centimeter pedunculated globular mass arising around above the anal verge along the right lateral wall. The surface was lobulated, the skin was stretched and erythematous with visible veins. On palpation, the external mass was firm in consistency and freely mobile. It was non-tender with no local rise of temperature. It was attached with a pedicle measuring around 1.5 centimeters in length and attached to the lateral wall of the anal canal. Also, the fullness was noted in the bilateral buttock, extending from the root of the scrotum till the anal verge and extending bilaterally till the ischial tuberosities. The skin again was erythematous and stretched and was freely mobile over the swelling. It was firm to hard in consistency, had a nodular surface, borders were ill-defined and immobile. Coming to the rectal examination, there was a firm to hard indentation felt over the anterior and lateral aspects of the anal canal. It started from the anal verge and extended about 7 centimeters proximally. It was nodular in surface, the mucosa was freely mobile, and we were able to palpate the pedicle at the 3 o'clock position, 1.5 centimeters above the anal verge. Now, looking at the patient now, there was a rapid progression in size. There was a change in consistency of the mass, and also the histopathology was inconclusive and there was a possibility of malignancy. So we decided to repeat the radiological investigations once again to determine the extent of the disease and invasion of the surrounding structures. I would like to invite Dr. Naman again to discuss the second part.
So these are the axial CT images demonstrating interval progression of that pelvic perineal mass lesion within a span of 2 months, just 2 months. See, this was the lesion before. Scan was acquired in 9 December 2024, and this was a large grown-up mass now. On 30th January 2025, just within a span of 2 months, this mass lesion has grown significantly in size. This is a follow-up MRI. Again, it is a large mass with lot of internal necrosis now, and the fat planes with adjacent structures anteriorly with prostate and posteriorly with rectum anal canal are all lost now, and there are a lot of necrosis and also showing heterogeneous post-contrast enhancement. And the size, combined length of the lesion has now become approximately to 10 centimeter. These are the sagittal CT images. This is a large. This is a large internal component, and this is the external extension of that large internal component, and it is extending into subcutaneous perineal region. So you can see the mass has significantly increased in size. So when correlating these both these scans just within a span of 2 months and observing a significant interval increase in size of the pelvic perineal mass lesion, the differential diagnosis must prioritize malignant soft tissue tumors, especially high-grade sarcomas, due to their rapid aggressive progression. Embryonal rhabdomyosarcoma remains most likely when there is a striking progression, even if initial imaging suggested benign features. Differentiating among the sarcomas often requires pathology, as imaging alone may not reliably distinguish them. So repeat or deeper biopsy is critical for confirmation from our side. So these are the key malignant differentials. It could be embryonal rhabdomyosarcoma, any other alveolar or other high-grade rhabdomyosarcoma, undifferentiated pleomorphic sarcoma, dedifferentiated or myxoid liposarcoma, malignant peripheral neural sheath tumor, or any other high-grade soft tissue sarcoma. And a rare possibility of malignant disease can also be included if there was any past relevant history. So I would like to invite Boss to come.
Thank you, Naman. Now, having narrowed down the differential to mesenchymal tumor of skeletal muscle origin, we had two possibilities. It could either be rhabdomyoma or rhabdomyosarcoma. And at this stage, as per the radiological imaging, core needle biopsy report, and the symptoms of obstruction like constipation and dribbling of urine, a decision was taken to proceed with the surgery first. Now, before we embarked on surgery, we had to define what the goals of our treatment were going to be. One was complete resection of the tumor with adequate disease-free margin in case it turns out to be malignant, to preserve urinary and fecal continence, to avoid injury to the rectum, bladder, urethra, and vas deferens, and preserve the pelvic floor strength. Now, operating in a neonate poses its own unique challenges, and especially in a closed cavity like pelvis and the perineum, there is close proximity of the tumor to the urethra, bladder, prostate, and rectum. The tumor was bilobed with an external component and making en bloc resection difficult. And also, because of the constraint in size, achieving adequate margins while preserving the vital structures was a challenge, and preventing fecal contamination of the wound as it is located near the anal canal. Coming to the operative procedure, the surgery was carried out by Dr. A.K. Shukla and team, and anesthesia team was led by Dr. Neelam Dogra and Dr. Ramat Chatterjee. Under general anesthesia, the patient was placed in lithotomy position. An anterior sagittal incision was made from the root of the scrotum till the anterior aspect of the anal verge, and bilateral skin flaps were raised. The tumor was found to be surrounded anteriorly by the bladder and superiorly by the bulbar urethra and the prostate, and posteriorly by the anterior wall of the rectum. Here, with the white arrow, we have marked the rectum, and this is the urethra, and this is the mass which is being excised. The tumor was carefully mobilized from the surrounding structures while maintaining adequate margins. And here we can see, after excision of the tumor, we can see the anal canal right here. And this was the tumor bed. Here, post-operatively, we can see the incision extending from the root of the scrotum till the anal verge. And we have also placed a corrugated rubber drain to prevent the seroma formation. Tumor was removed and blocked along with the external component. The anal sphincter was repaired. The pelvic floor was repaired and perineal body was created. And also a diverting transverse loop colostomy was done to protect the wound from fecal contamination. Post-operatively, the patient recovery was uneventful. Now, after resection, we forwarded the specimen to Department of Pathology for further categorization. I would like to invite Dr. Kiran Saini to describe the histopathological examination.
So we received in our department a formalin fixed specimen. So this was the part which was the inner component, and this was the part which was protruding outside. And this is also lined by mucosa. On cut section, the color of the tumor it was tan white to pale brown in color, mostly firm on touching. But all these pale areas which are pale white in color, these were the necrotic areas and were soft on touching. In the scanner view, this was the part which was taken from the outside part. This is lined by stratified squamous epithelium. Inner this is the granulation tissue. Most of the tumor proper was composed of long fascicles and bundles of spindle cells. In the high power, the morphology is quite similar to that seen in the core biopsy. The cells are spindle. They have long eosinophilic extension. At places, cross striations are visible. However, the chromatin is now more vesicular and nucleoli is still inconspicuous. But the worrisome features seen in this microscopy were in a single field, we could observe as much as 6 mitotic figures, which are these dense hyperchromatic structures without any definite nuclear margins. So the tumor had brisk mitosis, which was not seen in the core needle biopsy. Also seen were large areas of necrosis. Now this was the viable tumor, which is showing nucleocytoplasmic distinction, whereas on this part of the slide, the whole tumor is necrosed. So in the high power, this is the coagulative type of necrosis, and the ghost outline of the cells are maintained, whereas the nuclei are lost. So in some of the sections which were taken from the inner component, also seen were these bundle of mature skeletal muscles which were getting degenerated and atrophic, and in between were the tumor cells which were seen infiltrating. This also points towards the fact that the tumor could have possibly arisen from a skeletal muscle. So summarizing, a 2-month-old child presenting with a anal mass, a cellular spindle cell tumor of skeletal muscle differentiation with brisk mitosis, large areas of necrosis. So a final diagnosis of embryonal rhabdomyosarcoma was given. Now I would like to invite Dr. Khushbu to continue with the discussion.
Good morning, everyone. Post-op chemotherapy, child first came to Pediatric Oncology Department for the expert opinion of management of rhabdomyosarcoma. As per TNM staging, child was classified under stage 1, T2N1 M0, as the mass was in favorable site with size more than 5 cm, with fixation of mass to surrounding tissue, that is T2, with regional lymph node involvement N1, without distant metastasis M0. As per our protocol, we advise the pediatric surgeon to excise the mass and classify the clinical staging of the tumor. Mass was resected by the pediatric surgery department and sent for the histopathological examination. According to the reports, mass was completely resected with margin positive, so we classified the tumor into clinical group stage 2A. Child was classified under low-risk rhabdomyosarcoma as per COG-RMS stratification 2021, as the histology was suggestive of embryonal type of rhabdomyosarcoma with favorable site, that is genitourinary site, with stage 1 and clinical group stage 2A, according to which child was given vincristine, actinomycin and cyclophosphamide regimen 4 cycle followed by 4 cycle of vincristine actinomycin regimen. The chemotherapy was given for 24 weeks. In COG-RMS risk group assignment, low-risk rhabdomyosarcoma has 35% prevalence, among which after chemotherapy, 5-year failure-free survival approximately 83% and overall survival is 95%. Thank you.
Now, having established the diagnosis and completing the treatment, I would like to invite Dr. Pradeep Gupta to educate us with a small discussion on rhabdomyosarcoma.
Thank you, Suraj and team, for your nice presentation. Good morning to all. Actually, everything has been discussed in detail. I am just briefing about our rhabdomyosarcoma. Rhabdomyosarcoma is a malignancy of primitive mesenchymal cell origin, primarily seen in children and young adults. It is most common soft tissue tumor in children and third most common extracranial solid malignancy after neuroblastoma and Wilms tumor. RMS accounts for 5 to 8% of all pediatric cancers. Two histological subtypes, embryonal and alveolar, are common. Overall incidence is 4.5 cases per million children per year. Neonates account for less than 1% of all cases, and among them, perineal RMS in neonate is again extremely rare. Incidence is 0.05 cases per million live birth. So this case is among the rarest of rare. RMS shows some male preponderance. Male to female ratio is 1.5 to 1. Literature about RMS is limited to isolated case reports for neonatal cases. Largest case series is of 292 cases from French cohort, and largest case series reported from India is of 159 cases. Both the series are of adult population. Fortunately, a similar case of rhabdomyosarcoma was presented to us in 2019 and was treated and published by our department in JIAPS in 2019. RMS in neonates and children needs some special consideration because of organ immaturity. It limits chemo tolerance. Radiotherapy is to be avoided because it leads to long-term sequelae. There are some surgical limitations in neonates due to small anatomy and proximity to vital structures. In neonates, chemotherapy protocols are to be modified. The dose of chemotherapy is to be reduced. Some important tips for surgical resection. The rationale for surgery first approach is that it is most rapid way to ablate the disease and should always be done if subsequent cosmesis or function will not be greatly affected. A wide and complete circumferential resection with a margin of 0.5 centimeter of normal tissue is considered adequate. Other than extremities, surgery is difficult because of injury to organs, loss of function, and poor cosmesis. Any suspected microscopic or gross residual tumor should be marked with clips to guide radiation therapy or later re-excision if needed. Sentinel lymph node biopsy is not routinely recommended for pelvic or perineal rhabdomyosarcomas, but may be useful in paratesticular or extremity RMS. Prognosis, main prognostic factors are as following. The road ahead, regular follow-up to check for recurrence, colostomy closure after completion of adjuvant therapy, pelvic floor strengthening exercises once child can follow commands, assess for continence after 4 years of age. Take-home message, RMS tumors may present with distinct histological subtypes, features, and sites. Age at diagnosis, primary tumor site, size, and invasion affect prognosis. Nodal involvement not a death sentence, especially in embryonal type of RMS. Open biopsy is more better than core-needle biopsy is better than FNAC. And in last, multidisciplinary approach with adjuvant chemotherapy and radiotherapy offers best survival in cases of RMS. We also reviewed literature. Among them, most important is European soft tissue sarcoma study group. They have shown that 24 infants within 2 months of life reveals that 23 cases were having favorable histology and localized disease. No case need radiation, and adjuvant chemotherapy was given with a 87% overall survival. Other reviews are as follows. Thank you. Happy Independence Day in advance. Thank you. Now I invite questions from audience, if any, please. Yes, ma'am. Please, in mic, speak in mic.
Sir, I wanted to ask that the signs and symptoms of that constipation and dribbling of urine resolved after surgical treatment.
Yes, ma'am. Urinary symptoms of resolved after surgery, but because we have done colostomy, so we don't know about bowel. Bowel. Yes, ma'am. Yes, ma'am.
Good morning.
Yes, ma'am.
Nice presentation and nice case.
Thank you, sir.
Just wanted to add something to RMS.
Yes.
Because we get most of these RMS, they arise from head and neck.
Yes. Yes.
Almost more than 1/3 of RMS they are found in head and neck region, and we encounter so many cases in day-to-day practice. The problem with RMS is early diagnosis you can treat. The way it spreads to all the tissue planes and soft tissues, it's difficult to resect it. So something, not from the surgeon's point of view, something which can be accessible in RMS is best, because you don't have a definitive treatment for RMS till date. All the three modalities work together. So RMS, the important thing is early suspicion, tissue biopsy, and surgery. We have operated quite a good number of RMS
Yes.
in PMS, in mandible, this area neck, even mastered RMS we have reported.
Basically, it is most common site, sir.
Yeah. So I think it's like, just wanted to.
Thank you, Pawan sir, for your inputs.
I would like to say that we had little difficulty in initially diagnosing it, because usually in kids, like he said, head and neck rhabdomyosarcomas, and in the perineum you usually have embryonal rhabdomyosarcomas, which are round cell tumors. So they're usually labeled as malignant round cell tumors, whereas in this case they were very differentiated. So we thought it's a rhabdomyoma. But at the same time it was very different looking. So we also consulted our people at Tata Memorial and sent them the, asked them that you could help us in, solving it. So even they found it a little difficult, because they said in rhabdomyosarcomas, you usually don't find these striations and all. When you're finding these striations, that means it's a differentiated tumor. I mean, it's going towards the normal looking cell. So that's what initially we were thinking it was difficult, but when we finally gave it that it's very, KI67 was heavy, so we suggested that it could be, and then in the MRI it was infiltrated, so we concluded that it's probably a rhabdomyosarcoma. So after that, the whole resected specimen came to us, then it became much easier. And then it was spindle cell, it was not the regular one. So pathologists also get into the deeper aspects of doing things which are not of interest to the clinicians. So it was a spindle cell rhabdomyosarcoma rather than the usual malignant round cell tumor.
Thank you, ma'am. Thank you, ma'am. Yes, ma'am.
Last but not least, radiology. When this baby came, it was very difficult because there was good vascularity. I think the images were another. So we first thought it was a vascular tumor. But then MRI showed areas of diffusion restriction. So unfortunately, I think the baby went home. Otherwise, it would have been
Benign.
earlier resection.
Yes, ma'am.
So it is. I must say that the pediatric surgery department is doing amazing work. The type of tumors which come to pediatric surgery, unbelievable, and how they recover and go back. My congratulations to the.
Thank you, ma'am. Thank you, ma'am.
So today's CPC highlighted the intricacies and challenges faced by the Department of Pediatric Surgery in dealing with the agony of tiny patients and the importance of multidisciplinary approach in diagnosing the case. With this, we conclude the CPC, and I welcome Dr. Monica Jain ma'am to propose the vote of thanks.
So good morning everybody, and thank you so much for coming at the early morning hour. This is the best time how we can start our day with such a important case and a perfect case to be put in as a CPC, because it is truly a multidisciplinary approach. It was more special because there were diagnostic dilemmas also, as per radiology, Dr. Anu Bhandari madam, as per pathological point of view, Dr. Arvind madam, and as per the case presentation, it was one of the finest cases ever discussed with a very positive outcome. Important thing is that the child is still surviving, and you can see, in spite of the ignorance shown and lost to follow up after 2 months when it was dreadful, they were still able to do the surgery in such a successful way. My heartiest congratulations to the pediatric surgery team. Dr. Arvind Shukla, sir, you have been doing amazing surgeries, and the entire pediatric surgery department is doing a wonderful work, and we can see in the highlights of the department. So before concluding it, I know all of you are in hurry. I just want to request few things, as I always do. Sometimes people start calling me, you are an RNC inspector, but yes, institution cannot run without regulation. So it my earnest request to all of you to please go for the uploading of your documents on the RUHS affiliation site, because we have been crossing the last date. Secondly, you please continue to do the Abhas enable face authentication attendance, because we are in the show cause notice period. And the third and the last and the most important is on 12th of August, we are doing a national importance program on material vigilance, in which all departments have role to play. So I have shared that on various PHOD groups. Please nominate at least 2 persons, because Principal Sir has been very kind-hearted to organize that, taking the funds in his hand. I'm very much thankful to him. And so please do come on 12th August. It is a full day workshop. Happy Republic Day. And I can think the last and not the least part, मैं भाइयों और बहनों कह सकती हूँ, because Raksha Bandhan is approaching. So happy Raksha Bandhan and happy Republic Day in advance. Thank you very much. And tasty something is waiting outside with hot tea. Thank you.